A very warm welcome to everyone to this webinar, which is the second webinar in a series on pediatric quality of care. My name is Anne Detjen. I'm one of the co-chairs of the quality of care subgroup in the Child Health Task Force. The Child Health Task Force is co-hosting this webinar together with the Quality of Care Network. A little bit of housekeeping. We have French interpretation available. To access that, you have to click on the interpretation button at the bottom of the screen. Bonjour à tout le monde. On a la traduction disponible. Pour accéder à la traduction, s'il vous plaît, trouvez le button au bout de l'écran. Next slide, please, Tala. All right, so today we want to talk about measurement and the introduction of pediatric quality of care indicators in Kenya and Sierra Leone. Learn from the experiences in those countries and see how that can inform ways on how other countries can introduce and scale up pediatric quality of care indicators. As you all know, we have had standards for pediatric quality of care since 2018, and last year in 2022, a set of core indicators was published and then shared widely with countries. And now we look forward to hear first from Moise Muzigaba from WHO, who will introduce the indicators and provide an overview of an activity led by WHO to support the uptake of these indicators in 4 countries. Moise is a technical officer in the Department for Maternal, Newborn, Child and Adolescent Health and Aging at WHO Geneva. Then we will hear country experiences from Sierra Leone, shared by Dr. Binyam Hailu, who is with WHO Sierra Leone. And then we'll move to Kenya and hear from Bernard Wambu, who is a senior program manager in the Ministry of Health, Kenya, and Dr. Makeba Shiroya, who's a technical officer at WHO Kenya. So without further ado, Maurice, I pass it over to you.
Thank you so much, Annie, for that very kind introduction. I thought it would be ideal perhaps for context, to start with a brief overview of the 4 families of QoC indicators that WHO has recommended for measurement at country level. And I guess within this set of indicators, or these 4 families of indicators, we need to appreciate what each of these indicators families has been designed for. Starting with the first one, which has been coined the core set of QoC indicators. This is typically a small set of input, process, outcome and impact indicators that have been prioritized for use by different stakeholders across the health system hierarchy to track progress across levels. And it's the focus of the work that we've been doing in the 4 countries that Anne alluded to earlier. And then there's a set of quality improvement indicators that are typically used by facility-based quality improvement teams and supported by subnational structures to drive improvement work. These are not prescriptive in that quality improvement efforts change over time, and therefore the quality improvement teams may need to adopt indicators that are in line with their quality improvement initiatives at that point in time. And then there's recognition of the fact that at subnational structure, there are also measurement needs that exist there that may link to improvement work that is happening in health facilities. And it's important to also have the subnational performance indicators that, again, is a flexible menu of indicators that can support district or regional or state or provincial managerial and leadership functions in improving and sustaining quality of care. And then the 4th family is what we refer to as implementation milestones. And again, these are usually context specific in that they are derived from the program design and implementation roadmap. They are aimed at really tracking whether the implementation of the program is happening as intended. In some instances, there may be some preparatory activities that one needs to keep an eye on. For example, if a policy has to be developed, you want to make sure that you have confirmed that it has been developed. And then there are other ongoing activities that would need to be tracked. So, for example, if within the program they set out to conduct on-site support or training every quarter, you want to make sure that that is happening. So that's the fourth family of indicators that can be used to monitor quality. But our initiative has been focusing primarily on the core set of indicators. And the matrix that you're seeing here in the view essentially shows how each of these indicators can be used by different stakeholders and where you expect data collection to happen. And you can see there's variation as you move to different stakeholder groups as to the utility of the data from these indicators and how much of it has to be collected by different stakeholders. So the global core set of pediatric and young adolescent QoC indicators was born out of, as Annie said, the publication of the quality of care standards for improving QoC for children and young adolescents in health facilities that were published in 2018. And WHO and partners started to think of a way of developing indicators that are tied to these standards. Building on the work that WHO had done with the partners in the preceding year on developing the maternal newborn QoC indicators. So from 2019 to 2020, WHO led a multi-phase effort to develop a core set of 25 pediatric QoC indicators and a catalog of 172 QI type of indicators and their metadata, using the quality of care standards as the organizing framework. And to the far right of the slide, you see a diagram of the different phases that we followed and the process that we followed to develop these indicators. It was quite complex. And for those that are interested, we can provide in the link, in the chat box, a link to the publication that outlines how these indicators were developed. But in principle, both the core and the QI indicators were prioritized on the basis of the fact that they would measure essential tenets of pediatric QoC. But we were very, very mindful of the fact that at the outset that these indicators may not be feasible to measure and monitor across different settings, which gave birth to the idea of really trying to understand how they perform in various settings. And this is just a list of these indicators. I will not spend much time going through each of these, but essentially you have mortality-related indicators, so impact and outcome-related indicators. You do have some process-focused indicators. There are some indicators in the set that focus, for example, on the patient knowledge and understanding of the condition that they are being treated for, and satisfaction with the treatment process, some counseling, etc., which are traditionally, these are indicators that you don't find in routine health information system. So we were very much aware that some of these really needed to be tested in a real life setting to see how they perform and the extent to which countries are ready to take them on. So within the broader scheme of supporting the uptake of these indicators at global level, we felt that it was important to start with a few pathfinder countries. And since March this year, we've been working with governments and partners in Malawi, Kenya, Sierra Leone, and Uganda to see how we can support these countries to integrate these indicators in the national health information systems. And later you hear two examples from two countries on how they've managed to do this. Important to recognize that this work was funded by USAID, which was also the primary funder for the work that led to the development of this, the 25 indicators. We selected the 4 pathfinder countries on the basis of their potential readiness for and clear interest around pediatric and young adolescent QoC measurement, but most importantly, having a strong agenda around QoC programming at country level. So in each of these countries, there were 4 deliverables or 4 results that we were working towards. One was to make sure that the Ministry of Health and the partners working at country level are oriented on the 25 indicators as well as their metadata. That's quite important. And then we set out to assess the readiness of each of these countries to collect and report on these indicators, working closely with the Ministry of Health and partners to have an understanding of which of these indicators can be adopted in the short term versus medium term versus long term. And also we set out to support countries to divide a strategy on how they can operationalize the recommendations from these assessments to ensure that these indicators are integrated in their national health information system. And since this was a pilot of sorts, we sought to also harvest some learning from the process that would enable WHO to come up with an implementation blueprint that could be used in countries that have got a similar profile and also adapted in other countries that may be slightly different. There were a few activities that we carried out in each of these countries. The first one was the landscape assessment of the health services and their linkages with the health information system in a set of heterogeneous health facilities around the country. And this is important because we recognize that some of the indicators can be measured in, for example, a tertiary level institution, but not so much in a primary level healthcare facility. So we sought to assess different levels of service delivery to determine whether there was a need for a tiered approach to rolling out or measuring these indicators. And then a multi-stakeholder indicator and metadata mapping process that followed the landscape analysis, the synthesis of data from this process, and then a stakeholder briefing and planning meeting to see how the country can move the agenda forward. I'm not going to spend time on the process that we followed to do the actual service organization mapping and data flow, because I know a colleague from one of the countries will take us through this. But just to summarize that, when we visited each of the health facilities, we tried to follow the patient, because the pathway that a patient follows in a healthcare facility determines where the data is collected about the treatment process or the outcome. So we would start with, for example, the first point of contact and go all the way through to when they are discharged or they are admitted or they die. And then based on this information, we sat down as a collective of WHO, Ministry of Health, partners supporting the ministry, and use the template that had been pre-designed to map not only the indicator itself, but the individual data elements or variables that are required to calculate that indicator. So for example, for the 25 indicators, we had to map 317 data elements within each of these indicators, within those indicators, which sums up to a total of 951 assessments, because we mapped whether the indicator or the numerator or denominator or individual data element was collectible, whether it is being collected, and whether it's being reported. So that altogether constitutes 951 times that we had to go through the mapping process. And then out of these results, we made recommendations as to what we believed would be the time frame for the adoption of these indicators. So for example, if for a specific indicator, we had 100% of the data elements required to calculate that indicator, then there might be minimal effort required to adopt it. And that was recommended as a short-term adoption, et cetera. For the long-term indicators, there was no data, long-term adoption, there was no data element at all in the health information system that could be used to calculate the indicator. These are mapping results, an example from one country, just to show the complexity of health information systems. You can see that the child health QoC data is scattered in 54 HMIS registers. So if you were to harvest all the data elements required to calculate the 25 indicators, you would have to go through the 54 HMIS registers in these countries that are, and 10 complementary forms, which are aggregated into 5 HMIS forms before they are loaded onto the HIS2. This is just a summary of the the ability of countries to measure the indicators. You can see it varies, but there are some indicators that were consistently problematic in terms of the country having data elements required to calculate them in their HMIS. And out of the 4 countries, Sierra Leone, I guess, was the one leading the pack in terms of their potential to adopt the QoC indicators. 52% of the indicators that WHO recommends could be adopted in the short term. And this was followed by Kenya and Uganda, where 40% of the indicators are available, and then lastly, Malawi. So to close this all, I've sort of put together a couple of recommendations that countries wishing to do this could follow. So after the mapping exercises happened, and you have results on the country's readiness to collect and report on these indicators, I think it's important for the health information system or HMIS or MNE technical groups or division in the ministry to, first of all, have a discussion around the technical structure and operational requirements for integrating all the indicators, regardless of whether they are available in the system or not. Having that discussion to consider the material, human time, and financial resources that would be required to adopt these indicators is very important. And then also looking into the technical capacity of health facilities to collect, manage, and if data moves upwards, how it can be analyzed and used through the existing data system is quite important. And then the technical capacity of the program personnel, given that some of the indicators are relatively new, would the program personnel, for example, that use the data or other stakeholders, would they be able to understand the results from this data, etc., for evidence-based action? So once the HMIS or HIS or MNE technical units have considered all these issues, they would then come up with the recommendations that would be brought to the attention of the program division to sort of highlight the pros and cons of adopting the indicators from a technical perspective. Because some of the indicators require, for example, tallying data from different data sources into one summary register for it to be reported, and these are important to consider. So these recommendations will be brought to the attention of, for example, the Child Health and Pediatric QoC program review. Depending on the structure, this may change. And the leadership would ideally want to convene other stakeholders that have got a stake in child health at country level. I know, for example, that HIV, TB, malaria, nutrition, etc. Would want to have a say in what ultimately the country takes on. Review the recommendations in line with from the perspective of the programmatic priorities, for example. And then these recommendations would then be decided upon to decide which indicators should be adopted moving forward. And then the final set of priority indicators would be taken back to the HIS, HMIS, MNE units to develop a plan on how the actual operationalization will happen. And then maybe after that, a stakeholder meeting looking into what it would actually take to implement the plan and the kind of support needed would be very important. So I'll end here and I'll hand over to our colleague, Binyam Hailu, to take us through the plans that Sierra Leone has to move this work forward following the support that they have received from WHO partners. Over to you, Binyam.
Thank you, Moise. I think I've turned off my video not to affect my internet bandwidth. But thank you, Moise, for your really nice presentation. You have taken us through the process. I think the burden on me is lesser. I'll just run down, the Sierra Leone perspective. Next slide, Tala. So I'll take you through briefly the background of Sierra Leone in terms of, the health sector and what informed, the strategy, including the site survival action plan and how we really moved in terms of integrating, the pediatric quality of care indicator and the key recommendations and the next steps that we are really following. Next slide. So Sierra Leone is a small country with with a little more than 8 million population. We have a total of 51 hospitals, which is actually large compared to the population size. And we have also more than 1,550 primary health care units, which basically means we have achieved, a potential health coverage of more than, 100%. Our skilled workforce is really severely stunted, with which we are very far from WHO's recommendation. Every year we have close to 250,000 deliveries, and majority of them are delivering, in health facilities attended by a skilled nurse attendant. Next slide, please. Regardless of the improved access to healthcare, even an increase in maybe a better indicator around the processes, we have a very bad outcome indicators around the maternal mortality, stillbirth, and neonatal mortality rate. As you see, Sierra Leone is one of countries with high maternal mortality rate. Also, we have shown a significant decline in the last 2 decades. Stillbirth rate stands at 24, and neonatal mortality at 30, and under 5 mortality is under 5. Sierra Leone is leading basically in under 5 mortality rate. And we are very far from achieving, the SDG target. Next slide, please. Yeah, so Sierra Leone in 2017, immediately after EVD outbreak, we developed a recovery plan that's also managed to develop, critical policy and strategy documents. One of them was, the reproductive maternal newborn child and adolescent strategy that ended 2 years ago. And the strategy highlighted, critical bottlenecks and even interventions that will accelerate, reductions of maternal and child mortality in Sierra Leone. Having said, having seen, a big mismatch between the process indicator and impact indicator, the strategy identified strategy objective 2 as one of to be quality driven, and stated improvement of quality of pharmaceutical nutrition services at all levels of service delivery. So it was dedicated to improving quality of care in all healthcare delivery system. And in 2020, we also developed, a QoC roadmap, including, quality of care policy policy that informed, the quality of care interventions in Sierra Leone. Quality was also defined in that year, and it also encompasses, the critical dimensions that are around safety, timeliness, effectiveness, efficiency, equitability, person-centered, and integrated interventions. So Sierra Leone, being joining the network, also identified, essential critical objectives that aimed at reducing, mortality by 50% in learning facilities, as well as improving, experience of care in those facilities. Next slide, please. Sierra Leone also is investing in the healthcare with the principle of adopting, WHO's model of, live stage framework. So now there's a great ambitions and stewardship towards instituting, person-centered live stage framework or approach to service delivery. That means looking at, the different cross sections of the population to ensure everyone receives the high impact interventions at that particular age. And leaving, preconception care might not even or ignoring or neglecting, some of the package of interventions before birth might also lead to, a bad impact, during child and adolescent stages. It's for that reason, Sierra Leone has adopted, this framework. Currently, we are implementing in this one, this framework, and this framework has also embedded, in various policies and strategy documents. And we have also developed the EPMM and INA plan that covers for 2 years up to 2025. And Child Survival Action Plan was recently developed and launched. That also informs, the quality of care endeavor in Sierra Leone. Next slide, please. The CSA Child Survival Action Plan was developed this year, and it's aimed to run for 2 years, and it focuses around critical areas, and basically it aims to accelerate, mortality reduction by addressing specific causes of illnesses and deaths, including, health system issues. It also aims to elevate, child survival actions to the highest level of visibility and accountability, basically at ministerial level, cabinet level, and even above. It also aims to improve, quality of service delivery across the life course, including across the continuum of care. It also ensures, equity by ensuring, reaching, all children's in hard to reach areas. All this requires, an improvement in the collection, management, and use of child health data at all levels, and it's a critical objective of the action plan. And it also refocuses efforts with this holistic approach to prevent child deaths in Sierra Leone, basically bringing vertical programs together to make sure the impacts are felt and mortality is reduced through a collective approach. And it aims to reduce mortality of newborns to below 23 and infant mortality rate to below 25 and under 5 to below 71. Next slide, please. So having said this, how are we in terms of quality of care? Next slide. So Sierra Leone joined the network, in 2017, but program has not yet materialized, did not materialize until 2019, where a quality management program was established. Next slide, please. So joining the network, it enabled us, to leverage, resources, including, technical materials, and also push the quality of care agenda, in the country, which enabled us, to establish, a quality management program at national level, district, and also hospital level, where we have realized, the appointment of dedicated, quality of care officers at all levels. Tools and guidelines were also developed, particularly the QoC patient safety policy and roadmaps that we use as a reference, to push the agenda forward. Pediatric mortality audit was also instituted in all hospitals, and we have capacitated more than 500 healthcare workers. And global MND score indicator were also developed and adopted into the MND framework. And we are also in the process of finalizing the integration of the pediatric quality of care indicator based on the mapping that we have found. Next slide, please. So this institutionalization of the pediatric quality of care indicator started through 3-level engagement, including engagement of stakeholder and partners on the child care space in Sierra Leone. WHO headquarters led the process, and basically it started with a courtesy call and involvement of senior leadership of the Ministry of Health, including counterparts, partners, the UN partners, even the implementing partners, supporting child health efforts. So the initial step was to map out the indicator, which requires engagement of facility leadership as well as healthcare worker in the facility. So the team managed to meet with leadership of the health facilities to introduce about the intent of the exercise, and followed by looking at the delivery pathways, for the health services, particularly around the child health care, both at PHU, primary care unit, and at hospital level. And after the assessment, there was also debriefing, at the facility level, including to the ministry leadership. And at last, we convened a technical meeting with a broader RMNCH stakeholder in the country to garner views and identifying critical, recommendations, for the integration process. Next slide, please. So I don't think I need to go through this. Moise has already explained around the indicators. These are 25 indicators, and the mapping was based on availability of the data, whether it's available in the tool, whether it's reported, collected, and also reported. And the Excel-based tool was basically developed in that manner and facilitated easy collections of the information from the facilities. And also at last recommendations were outlined based on the mapping exercise. Next slide. So Sierra Leone HMIS, like so many other countries, we also use DHIS2. And there are 10 forms in the DHIS2. There are also 9 forms in the patient register where they are kept at the facility level. And also there are patient forms that includes triage forms, under 5 treatment register, patient charges, inpatient charges, and the like. So the sources are from primary. The forms are both in the hospitals and PHU level, and they are, as you see, they are HF1 to HF10, and they are it's around patient data as well as logistic informations around drugs and the like. Both hospitals and PHUs have also been looked at as part of the reporting unit. And as you see in the last column, all these sources, including the reporting units, have been checked for the mapping exercises. Next slide. So we just took an example of the slides. I may not see it very well, but I think you might have seen also from Mo's presentation similar indicator, similar a different indicator, but a similar template has been shared. This one is around KMC initiation for infants weighing less than 200 grams. So the Excel tool helped us to map out around the sources, around the definitions of the indicator, and whether they are available in the forms, as well as whether it's collected and reported. And also we have highlighted some feedback. So some requires
Okay, I'm not sure if that's just me. I'm not hearing Binyam anymore.
Yes, I think we lost Binyam.
Okay, let's wait briefly. If he does not join, then I suggest we move to the Kenya presentation and then come back to Sierra Leone after that. Let's see if he comes back in it. Yeah, can I suggest that we switch over to Kenya? Apologies for that.
Yes, of course.
Okay, so Bernard and Makeba, over to you.
Thank you. He's back.
No, I think we're just moving into presenter mode here. Yeah, you can go ahead.
I hope you can see my screen.
Yes, we can see it.
Okay, excellent. So thank you for the opportunity to present. The presentation will be I'll start off the presentation and I'll generally cover just a brief background on child mortality and the process that we went through for mapping of the pediatric quality of care indicators at the health facilities. And then I'll hand over to my colleague from the Ministry of Health, Mr. Wambu, to go over the implementation, challenges, and next steps. Kenya population is at about 53 million, And as you see from the graph, on the bar graph on the right, we're largely a very young population. And we currently the under 5s are probably about 3 million. In the map of Kenya, would like you to kindly appreciate the fact that Kenya is a devolved state. We have 47 counties, and health is implemented at county level. Last year, we got results from the Kenya Demographic Health Survey. And this slide would like to share with you the trends that have been in child mortality, the under 5 mortality, infant mortality, and neonatal mortality. On the whole, we've been seeing the decrease in mortality rate from over the last 20 years, from 2003. There was a sharp decline. And then over the last, from 2014, 2022, it's been more steady and not significant decrease in the neonatal mortality rate. And with the challenge is that with the current trend, we may not be able to reach our SDG goals. The leading causes for under 5 mortality include birth asphyxia, neonatal sepsis, pneumonia, diarrhea, malaria. All these are still similar to what have been in the past and still cause significant morbidity and mortality for our children. Now I'd like to go over the process of the health facility mapping for the pediatric quality of care indicators. This process was done with colleagues from WHO HQ, Dr. Moise, as well as other colleagues from AFRO. And we were also joined by colleagues nationally from the Ministry of Health, the Department of Quality and Standards, as well as Division of Neonatal and Child Health. The process of mapping commenced with the identification of the health facilities. As shared earlier, Kenya has got 47 counties, and 2 counties were purposely selected, Machakos County and Kajiado County. Within the counties, the health facilities are divided into different levels, beginning from the level 1, which is the community and the primary health facilities, all the way up to level 5. So in identifying the health facilities and the hospitals, we purposely selected according to the levels in order to be able to get a sense of the data elements that constitute the different pediatric quality of care indicators. So for Machakos, we went to the county referral hospital and the sub-county at Mutitini, and then Mwala was the sub-county, level 4 sub-county hospital, whereas Kajiado, which is really an ASAL area, which has pastoralist community, but borders Nairobi, we went to the county referral hospital, Kitengela, which is sub-county, and Bisil, which is a health center. The next slide just aims to show you that the teams that went to the health facility were quite diverse. From national level, we had representatives from different stakeholders. We had MCGL was part of the team, USID, as well as Save the Children. We also had colleagues from various departments, including M&E, standards, and then, of course, child health. At the county level, we were joined by various technical personnel after the introductions that were done at the level of the county health medical teams. And I'll now walk you through what the processes that took place at each of the different health facilities. I know that Dr. Moise has hinted at this, but we'll just go over it briefly so that you can appreciate the depth that went through in order to be able to map all the different data elements. So the process of mapping was really walking in the path of a sick child as they enter into the health facilities. And we purpose to go to every, the different service centers, service points that offered services to children. So our first contact was always at the registration to understand how children are triaged, how the information is keyed into the various systems, whether it was digital or it was paper-based. Kenya is commencing a digital process in some health facilities, and this is on trial basis. We engage the healthcare workers to describe the scope of work that they provide, and also to be able to, we also collected information on how they engage the patient as well as how they recorded. We collected various data tools, and in some cases, we're able to collect blank documents and then or take photos. For each of the tools, we were keen to identify those that were standardized MOH tools and when they were last updated. In some cases, there was improvisation and they didn't have the standardized tools. Some tools were project tools, where some tools were just facility innovative tools. Following that, we would then move to the next service point that the child would walk through until they actually are treated and discharged. And we repeated this process at the outpatient department, emergency, the newborn unit, the HIV/TB clinic, and the lab. In this slide, it's just to help you understand the landscape, the health information system landscape for the various data elements for pediatrics in Kenya. And we appreciate that there are about 4 main reporting platforms. So you have the Kenya Health Information System, which is an aggregate, which collects aggregated data, and then the KEMR, as well as the TB programmatic records. The summary tools are about 11, and then we have different individual patient registers and tally sheets, which are about 36. Following this process in all the different health facilities, we were then able to, as has been shared, to really focus on getting the 3 main outputs, which is to really assess what are the data elements that Kenya has as relates to the 25 indicators. And if subsequently, upon mapping of the data elements for each of the indicators, whether they were fully available, partially available, or not available at all. And based on that, would then be able to make recommendations to the country or to engage stakeholders to decide which was the best way forward in terms of adaptation of the quality of care indicators. In this slide, we are diagrammatically showing of the 25 indicators available in the Kenya Health Information System. About 7 are currently available and can be adopted immediately. And these include examples such as the institutional child mortality rate, KMC, as well as diarrhea, and the indicators related to pediatric malaria diagnostic testing and HIV testing. 3 of the indicators are not currently available, are partially available, whereas about 14, which are mainly related to experience of care, are currently not being collected, where the last indicator, which we could not accurately determine, was to do with the play items. There were other observations and recommendations that we were able to appreciate as we carried out the different mapping. And we noted that not all the indicators were available at all the level of health facilities. Recalling that Kenya is divided into from level 1 to level 6, we noted not all indicators were measurable at all the health facilities, hence a possibility of considering a tiered approach in Kenya. There was also the fact that when it came to the reporting tools for children, the reporting data for children under 5 and young adolescents, currently Kenya's data did not have specific provision for the above 5s and the adolescents, but at the individual health facility level, the data was being captured. On the aspect of mortality, the perinatal death audits were currently not being done, and we'll hear more about that from my colleague, Mr. Wambu. Some registers were not available. All these have implications when it comes to the adaptation and also the aspect of the use of composite indicators. The various stakeholders, as we discussed the data that we received, there were concerns or there were reactions about the usefulness of composite indicators, which have multiple data sets as opposed to single indicators. With that, I will kindly hand over to my colleague, Mr. Wambu, to continue to share with us more about the current country implementation roadmap. Over to you, Mr. Wambu.
Thank you. Thank you very much, Dr. Shiloya. I'll continue with the remaining slides on the country implementation. So actually, the country just finalized the adaptation or the development of the national standards quality for improving quality of care. And I think the mapping came after the right time when we are doing this, because we have been able to incorporate the recommended WHO indicators into the standards. Actually, I've also been able to incorporate our core indicators and also a health facility assessment tool for the indicators. And again, to mention, the quality of care standards for Kenya has 9 standards, including the community, newborn and child health care services, which we included to form as the link between the community and also the facility. As Dr. Shira said, we have care of levels. We are up to level 1, which is a community, going up to level 2 dispensaries and upward. So this is just to measure the issues of the community, the linkage, and also the experience of the community health for promoters in the assessment of a referral of the newborns, and also the issues of the integrated community case management, the ICCM. So these standards will be launched in November, when we have the world will be marking the World Pneumonia Day. So thank you. Next. So the approach which we had for this, I think we had a very extensive stakeholders review and discussions where we had our stakeholders as mentioned. And again, we had a very pure consensus on the indicators which we were discussing about, having the consensus of the indicator type, that is whether it's an input, an output process, and outcome indicators. Again, the data sources, and again, we wanted to see which are those indicators which are already in our NHIS2, the KHIS2 for the country. And again, we wanted to see about those indicators which are not corrected, but they have potential for correction in the medium and long-term period. And again, coming up with those indicators which maybe they are not routinely, but we need to correct them through the surveys, through the health facility assessment, and again, also during the support provision, going to the facilities. And again, you wanted to map these indicators with the global small and sick newborn and the pediatric indicators, which are available, so that we can have a comprehensive indicators for the quality of care standards. Next. So the results with the outcome of this, actually for the quality of care standards for the country, we came up with a catalog of 70 indicators. As I said, again, the country, the quality of care standards have 9 standards, and all these have quality statement and quality measurement, having to come with the inputs, the indicators, the process indicators, the output indicators, and outcome indicators, all of them. And then after that, we came up with a core 30 core indicators, which actually are already being corrected in the country through the national NHIS. So we are able to identify those indicators. And again, part of what was recommended by the WHO are actually integrated into the core indicator, which are in the KHIS. Then we have the Kenya quality model for healthcare, for the Kenya quality model for health, where there's a quality improvement initiative in the country. And also, we also need to have this so that we can be able to monitor our quality of care and the performances. We also have indicators which we can also develop a pediatric indicator dashboard to visualize the performance of these indicators as we move on for better decisions to improve the quality of care for our newborns and child. And again, there are those, the catalog of indicators, and we hope the planning process for the review of the KHIS in the country will be undertaken, so that some of the indicators which will be maybe for medium and short and long term, we can also be able to incorporate them into in the KHIS, so that we can be able to have the data for that. So some of the indicators which already were immediately adoption from the 25 core indicators, I think we mentioned by my colleague, Dr. Shiroya. Some of the indicators include the child mortality, the KMC, the pneumonia treatment, the management of diarrhea, the malaria diagnostics, uncomplicated severe malnutrition, the TB missed opportunities for vaccination, including the use of antibiotics. Next. So we also, when we are doing the mapping, we also have we have noted there was a gap, especially for the pediatric and the neonatal and pediatric review. And the country is adopting the pediatric death audit guidelines as per the WHO. So this is a process ongoing. We have a draft. And again, we also planned to have to finalize these guidelines so that they can strengthen the issue of the neonatal and pediatric deaths audit in the country, where we saw there's a gap, especially when it comes to pediatric death audit. So these guidelines will assist to strengthen the system on mortality reviews in the country. So I think it's a process which is committed and be able to finalize these pediatric death audit guidelines with the time. Next. So some of the challenges, I'll just mention some of the challenges and opportunities which what we noted when we are mapping the indicators is that the lumping together with the above 5 and young adolescent data with the adults. We have the other 5 data reporting tools, but now when we go to disaggregating the data for the above 5 and the young adolescents, they are lumped together with adults, which is, I think, a challenge. But I think the facility registers have the provision for the age disaggregated data, which can also be, we can be able to report as we move on. This mostly the outpatient morbidity reports. Again, I think we mentioned about the gap in the neonatal and pediatric mortalities. And I think I have mentioned that the country, the ministry is developing the pediatric and neonatal mortality guidelines, which will be able to, as we move on, will be able to be used in the country. Another indicator we noted was the kangaroo mother care indicator, which was a bit of confusion with the skin to skin, but also the country is reviewing the KMC guidelines and scale up plan for KMC, and so reviewing the kangaroo mother care register. And again, these documents, I think they are already being finalized. And during the World Prematurity Day, that is 17 November, we'll be able to launch these guidelines so that they can also be able to help in the reduction, especially for management for the kangaroo mother care in the country, towards reduction of the neonatal mortality rate. Thank you. Next. Yeah, another challenge I think is the short supply, and also we noted poor or incomplete documentation, whereby some of the other 5 register, whereby missing some vital signs like height, temperature, and oxygen saturation readings, and maybe some of the missing treatment. But I think, as we said, we have partner support to this. And again, also the county government, as mentioned, we have 47 counties printing more registers so that we can have them. And again, the need for routine quality data audits to improve data quality for better decisions. Another challenge is the EMR system. There's issues of interoperability with the KHIS. Some of the EMR systems using the old versions of the tool are not able to actually link with the KHIS for data. So it makes a bit tedious for the work to be done to collecting from the EMR and again to the KHIS. But I think for this, the country actually, there's a digital platform to standardize and integrate all their facilities, especially when it comes now to the issue of EMRs, where we have a standardized, integrated EMR for the country. Just to minimize the issue of the data quality, and also making the report very standardized and well done. I think further opportunity we have with the partner support. We have quite good support for our partners, USAID, WHO, UNICEF, Path, Save the Children, among others. We have been working together, especially in this process. Next. So I think the next steps is to the review of the HMIS, so that we can have the pending quality of care indicators to be considered for inclusion when we review the HMIS tools. That is the tools, the registers, the reporting tools, the summaries, and also the indicators that you can be able to include the pending quality of care indicators as we move on. I know maybe this will take some time, but I think the process for the review is almost. And again, there's need to disseminate the national standard of improving quality of care, which I think we have developed. So we need to disseminate this to all the counties. Actually, in the counties, that's where the implementation is. So definitely we need to disseminate this, because also our indicators are included in this quality of care document. Then the other one is to finalize the pediatric neonatal mortality guidelines. I have said there is a gap, but we need to finalize this so that we can strengthen the process of the mortalities for the pediatrics units. And again, the development of the dashboard, which will be able to visualize the indicators, the trends, and so that we can be able to make our decisions and have real-time data available for us to make informed decisions. And again, to incorporate the indicators into the Kenya quality model of health in the country. Next. Here are some of our key players in this. As I had mentioned, we have quite a number of key divisions in the Ministry of Health, the Division of Neonatal and Child Health, the Division of Health Standards and Quality Assurance and Regulations. They have been with us in the process. The Division of Family Awareness and Nutrition, Health Informatics, which is very key to this process. Then the Reproductive, Maternal, and also Community Health Services. Also the county government, we had representation of the county government, because this is where the implementation of these guidelines are. And again, also we have the WHO, the UNICEF, USAID, we have the KEMRI, we have PATH, we have Living Goods, Save the Children. We also have CIN, the Clinical Information Network, who also have been together with us in this process. Next. So thank you very much. And thank you for listening to Kenya and the process of integrating the pediatric quality of care indicators in the National Health Information System. Thank you, and back to you.
Thank you so much to all the presenters, and apologies for the bad time management. And Binyam, sorry you dropped out. We don't really have much time for questions and answers anymore. We did respond to a lot of questions in the chat. I think the point is that it sounds maybe a little bit overwhelming when Maurice started to talk, but Maurice, I thought you had some extremely practical recommendations in your slides on how countries can go about looking at the indicators, seeing what they are already collecting, and how they can move towards adopting additional indicators. And then that was supplemented by the great work that is done in the countries. We will be sharing the slides and the presentations on the Quality of Care Network and the Child Health Task Force websites. I think it might also be good if we just summarize maybe the key recommendations and learnings in 2 pages. I think that's the kind of resources that I think Tomomi asked about in the chat. I maybe want to give Binyam, if you have 30 seconds to just share sort of the key next steps in Sierra Leone based on this exercise. I give you that time. if you're here.
So, and he said he had tried to join by phone. I don't know if you see him online.
So Moise, is there anything from Sierra Leone that we didn't hear that you think is important to quickly share with the group?
Yeah, so there are some important next steps in Sierra Leone that they've been considering. One is to develop a results framework in line with the Child Survival Action Plan, and this is an ongoing effort. And then the directorate and programs would like to review the indicator dictionary, and again, that's also ongoing. And then a review of the HMIS forms to ensure that the essential data elements are included and eliminate redundancies, which is to Zodi's point to say, do we really need to be collecting some of the indicators that have been there for quite some time? There are also other activities that are planned in Q1, including the review and harmonization of the national HMIS forms. They would like to do a nationwide capacity building program based on the new HMIS, THIS2 adaptations, targeting the relevant stakeholders, etc. And then in 2024, there's a plan to scale up the electronic medical record management system in hospitals, including the online reporting and summary form. So things are really looking up for Sierra Leone, and I quite like the linkage with the Child Survival Action Plan that I know Anne, you are involved in, and a few other colleagues. Over.
Thank you very much, Moise. And I think indeed, I think this is an opportunity to improve what we all know is a major issue in many countries, which is the quality of basic child health services, and particularly IMCI, and extending that also to community level. This is an opportunity, and I see this is a question that was actually coming in the chat, to bring the different programs together. Yared, I see you raised that question. So maybe the Kenya team wants to actually very quickly say something. I'm sorry, we're running over for those who have time. On how did you bring the different programs together, malaria, nutrition, because there are indicators among the core indicators that really have IMCI as a strategy in mind, and rely on the programs to jointly think about which are the indicators that we want to prioritize, that we collect to monitor quality and then decide on action. So Kenya team, do you have 30 seconds to say something on the coordination between the different programs?
Yeah, thank you very much. I think, as I mentioned, we have collaborative meetings, and again, consensus building. And again, we have been having the divisions, especially the key divisions in the ministry, standards and quality assurance, the health informatics, which was very important, the nutrition, the reproductive maternal services, and also the community health services. So we are collaborating in all these, and when you are developing these co-indicators, and also when we come to integrating services in the ministry. Thank you very much.
Thank you so much. So we hear the questions in the chat on practical resources, practical recommendations. We will keep that in mind and see how we can summarize what was shared here. We hear the call for materials and resources in French. We will also see how we can improve on that. If there are topics that you would like to be addressed in this pediatric quality of care series, please feel free to reach out to myself or Patricia Jodry or Peter Waiswa. We are the co-chairs of the pediatric quality of care subgroup, or to the quality of care network, and we will keep that in mind. We are already discussing following webinars that talk very practically about experiences from countries on quality improvement efforts for pediatric quality of care at health facilities. We're talking about a zoom in specifically on IMNCI and what are some experiences, not only by child health programs, but maybe also led by malaria or nutrition colleagues on improving quality of care of IMNCI. I also want to make you aware of an upcoming webinar on the 31st of October on actually strengthen responsive caregiving and early learning in nutrition services. This is work done by Advancing Nutrition. The information will be shared via the Child Health Task Force. So with this, thank you very much again to all the presenters, all the great questions coming from you in the audience, and we look forward to seeing you soon in the next webinars. Bye-bye.